Right. Well, wonderful. And let me just officially welcome everybody to tonight's Pediatric Vascular Surgical Interest Group webinar. I did want to just share a couple introductory comments for anybody that's new to the group. This is a really important collaborative effort that is kind of connecting two broad disciplines in the space of pediatric surgery and vascular surgery. So I think across our APSA and SVS membership, it's become quite clear that we have a real opportunity to work together, learn together, explore together, and think about how best to optimize the landscape of care for pediatric pathology, vascular pathology, for the rare but really special patients that we all cross in our practices. This interest group has been a really nicely sustained byproduct of this collaboration. And I just need to recognize and express my own gratitude to our APSA and SVS leadership before we sign off for tonight. And so to ensure I don't forget, I want to absolutely thank Mary and Riva, both whom are with us this evening, who've been supporting us on the SVS side to really execute all of the things that have gone alongside this collaborative work. David Rothstein and Regan Williams have been our APSA co-leads. John White has partnered with me on the SVS side, and we've got a tremendously engaged task force. So I just want to say thank you, and it's been super fun to watch our kind of virtual collaborative grow over the many months that we've been doing this together. We listen to all of you, and following this webinar, Mary will reach out and get some feedback from you and seek ideas that you'd like to see prioritized for future webinars. But based on feedback from all of you as stakeholders, we've really selected tonight chronic venous disease with a specific emphasis on KTS. I wanted to preface this webinar by just reminding folks that we have had some extended discussions around previously venous thromboembolism, acute thrombosis, and also vascular malformations in a way in which those are not going to be emphasized heavily tonight, but we certainly can circle back to any of these concepts in the future. So with that, I'd like to just kick things off and share that we've had two gracious speakers agree based on their own respective clinical expertise or content expertise in the KTS space to join us this evening. Dr. Wright, if you don't mind, I might introduce you first to kind of start us off with the presentation that you've prepared. Dr. Teresa Wright is joining us tonight from Memphis and Lebanon Children's Hospital specifically, where she currently serves as chief of pediatric dermatology and is a professor of pediatrics through the University of Tennessee Health Science Center. She's supported multidisciplinary care for a variety of really rare conditions that certainly some of which have been prioritized with this group, and some of these things we all see respectively. And I think bringing your background with your own specialty expertise, Dr. Wright, is going to be invaluable to all of us. And so thank you in advance for starting off our discussions around Klippel-Trenaunay syndrome.
Well, great, wonderful. Thank you. Thank you for the introduction. And thanks so much for inviting me. I'm happy to be here. Let me just share my screen quickly to get my talk up here. Okay, great. So I was asked to kind of cover a broad overview of Klippel-Trenaunay syndrome. I don't have a lot of time, so this will be very, the big picture, a very broad overview. I'll be happy to try and answer any questions. So of course, the first question is really, what is Klippel-Trenaunay syndrome, also referred to as KTS for short? And basically, it's considered a PROS condition, and PROS stands for PIK3CA related overgrowth spectrum conditions. And this refers to really a wide array of disorders that are characterized by vascular malformations and overgrowth of soft tissue and bone, which can occur in a lot of different locations and in different combinations. If you're looking at the most recent definition by the International Society for the Study of Vascular Anomalies, or ISVA, it's basically a triad of a capillary malformation on the skin, which would also be known as a port wine stain or a port wine birthmark, along with venous malformation. And usually there's a very superficial component of venous malformation that you see on the skin as varicosities. And then they have limb overgrowth, which is soft tissue and typically bone as well, and then with or without a lymphatic malformation. And this condition is caused typically by sporadic postzygotic mutations in this PIK3CA gene. And so just to show you a picture of, this is an adult patient, but you can really see all of those features. The classic triad here, you can see the port wine birthmark, which is this very deeply colored purple geographic patch here on the leg. You can really appreciate the nodules that are the varicosities here, and you can see the size discrepancy between these legs. So those are really the features that you're looking for that really would define that as Klippel-Trenaunay syndrome. So looking at each of these features a little more closely, so the capillary malformation, or the port wine stain, as people call, or I've had it called the pork rind stain, which I love since I'm here in the South. Always get a giggle. But these will be present at birth, and usually the ones we see with KTS are going to be a very dark red or purple color and have this very geographic shape, so kind of sharply demarcated edges. In terms of the venous disease, the varicose veins, they can appear very early. So we can sometimes see them in very young children, and they do tend to have a tendency to worsen and become more prominent over time. These patients can also have abnormalities of deeper veins, and sometimes they are at risk for deep vein thrombosis. Fortunately, that's rare, but it can happen. And then when they have lymphatic malformations, so these can have different features. So they can be microcystic, where you have tiny little kind of vesicular sacs of fluid, or they can be macrocystic, where you have larger cystic lesions that contain fluid, or they can be mixed. And I have here a photograph showing a microcystic, because frequently you'll see patients present with these collections on the surface of the skin. These can be mistaken for lots of things, molluscum and warts, and just all kinds of things, because you have to look really closely sometimes to appreciate that many of these have fluid within them. Sometimes this is referred to as a frog spawn appearance. It kind of looks a little like frog eggs or fish eggs up close. But these, can be traumatized easily sometimes, and they can leak. They can fill with blood, and so they can leak blood or lymphatic fluid. And then when there's open areas, they can be at risk for infection. Over time, patients can also develop lymphedema and something called pseudoverrucous hyperplasia, which is where you get kind of thickened, warty looking like bumps over the affected areas of skin. If you see patients with lymphedema or just kind of chronic stasis or edema, I'm sure you've seen those. In terms of the overgrowth, that's typically going to be present at birth, especially for patients with a more severe presentation. And it's an overgrowth of soft tissue and bone in most cases. The limb is usually longer and larger, although, it of course varies, the size discrepancy varies. And it can be progressive sometimes, although oftentimes it will end by the end of adolescence. Some cases do continue to be progressive. And sometimes other limb anomalies can occur, like abnormalities in the toes and other abnormalities as well. So in terms of the common complications that we see or that we're on the alert for, so clotting disorders can definitely happen. You have these sometimes extensive venous malformations, which, as you know, are slow flow, low flow lesions, and they can have some clotting, especially low level chronic clotting that can occur with them over time. And that can cause us intravascular coagulopathy. They do have some increased risk of superficial thrombophlebitis. And then again, rarely DVT and PE, fortunately, those are usually going to be larger, deeper veins, particularly, ones within the abdominal cavity. And we can also sometimes see bleeding. So I already mentioned the bleeding from the microcystic lymphatic malformations. They frequently, will get traumatized. They'll fill with blood. They'll start to bleed and ooze. And then rarely for larger venous malformations. Sometimes you can have some severe bleeding. Luckily, that's not very common, but it can occur. The limb length discrepancy, that's something that we watch for very carefully. If there's more than a 2 centimeter difference, that's where you're more likely to see a real functional impairment. And as I mentioned, the growth most of the time seems to stop by the end of adolescence, but not always. The other complication, and some of these things I'm going to mention more than once because they're just kind of the mainstay of taking care of these patients, the chronic lymphedema and venous insufficiency, which clearly puts them at risk for the complications that go along with those things, the stasis, the risk of infection, the chronic ulcers. So just like with any condition, that causes edema, we spend a lot of time talking to them about good skin hygiene and avoiding, things that might make them prone to open wounds that may not heal well on their lower extremities. And of course, infection, cellulitis. Sometimes we see patients with really severe cellulitis in these who, end up admitted to the hospital for treatment. And then very often, especially when they're more extensive and over time, they start to have pain, which is really multifactorial and can be due to anything from, clots and swelling to neuropathic pain, etc. So to make the diagnosis, this is generally a clinical diagnosis just based on those features that I showed you in those pictures, the things that you can see looking for that primary triad of features. Imaging can be helpful. Clearly an ultrasound with Doppler can help us to see the anatomy of those superficial and some of the deeper veins. Can also help us see if there's some degree of thrombosis there, or if they're forming phleboliths, which is where they get the blood clots that calcify over time and causes kind of subcutaneous hard nodules that can often be painful. And then sometimes MRI is really useful because that can obviously show us more details on the exact nature of the lesion, what's involved, as well as the extent of the involvement. Other studies that we get sometimes, basic labs looking at a CBC, a D dimer, which if they have a chronic consumptive coagulopathy, the D dimer is typically going to be elevated. We look at fibrinogen, which may be maybe within the normal range or maybe somewhat decreased, and a PT-PTT. Those can give us clues if patients are having, chronic clotting within their malformation. And then a biopsy. When do we biopsy? We don't usually need to do biopsy and get tissue to make the diagnosis, but especially in the last few years, getting tissue can be helpful for genetic testing sometimes. And there are a variety of overgrowth panels that are available now, which test for that PIK3CA gene mutation, along with some others, which are sometimes involved with some variations on this syndrome and some related syndromes like the GNAQ and GNA11, and there's some others as well. And then for management, they're ideally managed by a multidisciplinary vascular anomalies clinic, which, can include many different specialties. I've listed some of the mainstay here. At our clinic, we have peds derm, interventional radiology, plastic surgery, vascular surgery, ortho, hematology. These are, all specialties that we call on and work with regularly for patients that we see in our clinic, PTOT, and pain management. And then in the broad picture, management is really all about supportive care for the majority of these patients. We're trying to prevent the progression and complications as much as possible, and then manage any complications as they occur. And clearly, management is going to be based on the severity and the type of problem that they're having. So to go through a few of those, as I've already mentioned, the edema, which can over time sometimes become quite severe and is obviously a chronic problem. We rely heavily on compression in a lot of cases. And, we have someone who comes to the clinic to measure patients and fit them for compression garments. Ideally, you want your compression garment to fit from above the affected area, and then also to go to the distal extremity and cover the distal digits. And it's been shown that use of regular compression, can decrease that risk of cellulitis and chronic wounds, just by decreasing the amount of edema. It can also be helpful to increase mobility and just provide some comfort. Compression garments are definitely not always practical, especially for younger children who often don't tolerate them well, and they tend to grow really rapidly and outgrow them. So you kind of have to put some thought into, at what age the compression garment is going to start to be helpful for them. Other things that can be useful for edema are lymphatic massage and physical therapy, as well as, the patient having some degree of regular physical activity to keep, the fluids moving. For likely discrepancy, when we are seeing that, or we know this is a situation where that's probably going to occur, we really like to get ortho involved quite early. It's important that they see the patients early. If the discrepancy is less than 2 centimeters in general, they will manage that non-surgically with things like shoe lifts. If it's more than 2 centimeters, that's when it's more likely to cause a problem. And they may consider something like surgical obliteration of the growth plate to halt the growth of the leg that is larger. And then from a medical standpoint, these are kind of the main things that we focus on. If we've identified a coagulopathy, doing what we can to treat and correct that, treat and prevent infection, pain management, and then now we have some pathogenesis directed therapies that we can offer when indicated and when it is possible. And just briefly, in terms of each of those conditions, so for chronic coagulopathy in general, if it's mild and they're having some mild pain or other symptoms, sometimes low-dose aspirin can be really helpful. If they have a more severe coagulopathy or have had a history of something severe like a DVT and or a PE, then clearly they need long-term anticoagulation, which our hematology colleagues are quite helpful to treat those patients with those issues. And then infection, we just want to be on high alert for signs of infection. So really counseling patients about what to look for and to, get seen and get treated early so that they can get the proper treatment. I'm always a big fan of trying a culture if possible. Clearly, we're looking mostly at, skin type organisms that get in there and cause these infections. But if there's drainage or a way to get a good culture, just to have that information and make sure that they are getting an antibiotic that is going to be most effective for them, I think that's always helpful. And then if we have patients who are chronically or like constantly getting infected, sometimes we might consider having them on some antibiotic prophylaxis, but that's very rare in my experience. And pain, so circling back to pain, as I mentioned before, is a multifactorial problem, and it can be very challenging sometimes for patients. Again, thinking about the possible underlying causes, such as infection or clots or contractures, or could it be neuropathic pain, and trying to pinpoint what the factors are can sometimes help us offer some effective treatment strategies. Surgery or endovascular intervention, we do pursue those avenues sometimes, and typically that's just going to be something to reduce disease burden. Most of these lesions are so large you can't possibly completely excise them, but sometimes problematic areas can be surgically excised. Sometimes we have lesions small enough that they can be excised, but very often that's not the case. We do have interventionalists who do quite a bit of sclerotherapy, which can help with symptoms, and reduce the disease burden as well. And then for targeted systemic therapies, now we have a couple of main options: sirolimus, which is an mTOR inhibitor, and it can be helpful for the right candidate. And we have actually started to use some topical sirolimus on occasion, especially for patients with superficial lymphatic malformations. And we've seen some pretty good results with using that topically, which has been a big help for some patients. And then alpelisib, which is a PIK3CA inhibitor, was just FDA approved back in 2022 for patients 2 years and older who have severe PROS problems and complications. And that medication can also be quite effective for the right patient in the right setting. So we are excited that we've had those options come along. And that's my overview. And so thank you. And this is my email address. So I'm always happy to hear from people or try to help or answer any questions. So I like to give my email address. But if you do email me, please note that they did not give me the T on the end of right. So it is TWRIGH43@UTHSC.
Oh,
Thank
Dr.
you.
Wright, that was such a great overview. Thank you so much for sharing all of that. And I'm going to look to David right now just to get his thoughts on whether we should kind of pause for some questions now, have people put them in the comments, or move along to Dr. Lohr's talk to kind of continue the KTS discussions and then open it up. What are your thoughts?
Why don't we do chats? I'll keep track of them, and then just to make sure we have time.
Yep, perfect. Okay, so if y'all don't mind, as you have questions that develop for our speakers, please put them in the chat. We'll keep an eye on it. And then just to kind of keep our cadence moving forward, I'll take the liberty then of introducing next Dr. Joanne Lohr, who's also joining us from the Southeast, where it's finally starting to warm up. Dr. Lohr is a vascular surgeon that shares some roots in Cincinnati, Ohio, and she served the patients there locally for decades before more recently relocating to South Carolina. She's a practicing vascular surgeon now at the William Jennings Bryan Dorn VA Medical Center. And she's been a longstanding noteworthy leader amongst our specialty and has served many roles, but probably most relevant for tonight's presentation, president of the American Venous Forum. I've watched and admired Dr. Lohr for a long time, and I'm sure, Dr. Wright, if we had crossed paths sooner, I would say the same about you. But Dr. Lohr has been a kind of fierce role model to me as a woman vascular surgeon. And I remember learning from her at a VEITH meeting many years ago and listening to some of her experience with some of our most challenging adolescent patients in particular, and asked her to kind of help us this evening with a bit of case-based discussion around women Klippel-Trenaunay patients in particular, and she was gracious enough to oblige. So thank you, Dr. Lohr, for supporting this tonight.
Dr. Coleman, thank you for that gracious introduction. And Dr. Wright, thanks for setting this up perfectly. Go ahead. We're going to talk about 3 patients that I've cared for, a couple of almost 30 years of care of these young women. And then I've got a case of an elderly woman who presented late after in life with some of the chronic changes, just to share with you. So this has been well defined by Dr. Wright. So we'll go ahead to the next slide. So the first of these 3 patients was diagnosed at age 14, then at 26, and then at age 30. They all 3 had thrombophilias, and they all 3 had multiple SVT and DVT episodes. And as I said, I followed them for one of them for almost 30 years. And we're going to go through some of their changing life crises that we were able to deal with. So go ahead to the next slide. The first patient was a 30-year-old medical assistant who'd had Raynaud's and blue spots and pain and tenderness. She'd had a couple of biopsies of these blue spots that were not diagnostic. And now you have to remember this was in the early 90s. So we took care of her for a long time. And before we knew what we really needed to do or really understood things, she was started on birth control pills at one point and had more pain and had then ultimately a cavernous hemangioma soft tissue biopsy. And ultimately she developed some headaches and was found to have intracranial malformations. And then as she aged, she started to have some spontaneous uterine hemorrhaging. Go ahead to the next slide, please. And here you can see some of her intracranial lesions. She was able to be maintained on her anticoagulants with the Association of the Neurosurgeons. And you can see here she actually had some significant lesions that extended from C1 to C6 with some changes in C2. As she aged and gained weight, she had more symptoms, more headaches. They became more disabling, and pigmentation increased, her disability increased. And then she developed a spontaneous vaginal bleeding that was going to require a hysterectomy. Before she was given anesthesia and things were decided, we did spine and pelvic imaging. She was not thought to be a candidate for a vaginal hysterectomy because we couldn't control potential hemorrhage. So those are some really important things to think about. And also, when she had her last pregnancy and we knew all of this intracranial things were going on, she was not a candidate for a vaginal delivery either at that time. So some things there. We did test her for her hypercoagulabilities, and she basically had factor V high Leiden heterozygote status, abnormal APC resistance, increased factor 12. And then she continued to progress throughout her lifetime in my association with her to develop new ongoing lesions. Some of these new interventions may have been helpful if they had been available sooner for her. So go to the next case, please. This is a lovely young lady. She's one of my favorite people. I got a call from her primary care doctor saying she's got these blue spots on her arms. Nobody knows what they are. She won't move. Her personality's changed. Her parents are ready to kill her. And would you see her and tell me what you think can be going on? She had been born with these blue spots on her shoulder and arm. And now when she hit menarche, she wasn't moving her arm. She wasn't moving her shoulder. And she had these painful lesions on her forearm. Go to the next slide, please. And here you can see it's kind of a soft shadow up around her shoulder girdle and then down and extending into her forearm. Go ahead to the next slide. And here you can see the subcutaneous lakes and pools that did extend into the deep muscle. And she really clinically had an SVT. Go to the next slide, please. Which was easily diagnosed clinically. Her father was a large fireman and her mother was a very small, petite woman, and they were so happy they had an answer. They were not happy to hear that she needed to start on anticoagulation. But as soon as she got on her Lovenox, her symptoms went away. She had an explanation for what was going on, and her personality started to switch back to her bubbly self. We got her in a compression sleeve, and she had always wanted a tattoo. Go to the next slide. The joke with her was that her father would never let her have a sleeve, so we got her into some diva sleeves. So once she got back to being her normal self, she got all A's, and her dad got her all the diva sleeves she wanted every time she got a perfect report card. But she is interesting because she also had factor V Leiden, homocysteine was normal, and her prothrombin gene mutation. The rest of her workup was pretty normal. But we needed to maintain her and then talk to her about birth control as she got into college and went on to do all the things kids do. Whenever her parents were having a hard time with her, they'd bring her to me and say, do something about her. she's messing up her warfarin, she's drinking, or she's doing something else. And so I almost became this kid's mother. She's now graduated from college and got married. So the next crisis for her will be her childbearing time. But one of the things about dealing with the adolescents is you have to connect not only to them, but to their parents. And so she stopped missing school and really blossomed back to the young, bubbly person she had been. Go to the next slide. And then this last young lady was 26 and had gotten married. She was actually one of my demo patients when we had the vascular fellows course in Cincinnati, and Tom Wakefield from Michigan was there, and he looked at Beth and said, "You have all of these findings. How do you know so much about them?" And so part of her deal and part of all of these people is you have to educate them, because this is something they're going to live with for the rest of their life. And so she could tell him everything about her disease and her underlying anomalies. But she and her husband wanted to have a family. They got in with the maternal fetal people, and we knew she had had issues and was needing to be anticoagulated. So we told them, please only put in 2 fetuses. Well, they put in 3, and all 3 fetuses took. She was obviously being treated with Lovenox throughout the pregnancy. And unfortunately, at 21 weeks, she started to have hemorrhaging and bleeding from her bladder. She underwent a cystoscopy, showed the bleeding was coming from her right kidney. She was transfused. We needed to stop the anticoagulation. And then she went into spontaneous labor, and all 3 fetuses were lost at 21 weeks gestation. So that was quite distressing for her and her husband. She subsequently went on to have 2 normal deliveries. I'll go to the next slide, please. And here you can see her limb discrepancy and the size discrepancy. Go to the next slide. And here you can see some of the gestational sac. One of the things about dealing with these young women when they're going to be pregnant is what kind of anesthesia and what kind of delivery can you do. The malformations change with estrogen, and they change during the pregnancy. So as part of the team and the planning, late in the 2nd trimester and the early 3rd trimester, you need to get current spine and pelvic imaging to determine where you could do a C-section safely and how you can approach this, because they can have a significant hemorrhage. And like the first patient I showed you, she would not be able to have further vaginal deliveries because of her intracranial and spinal lesions and the risk of hemorrhage. Go to the next slide, please. And this is a young lady that presented to me very late, just to show you what the long-term sequelae can look like. Here's you can see in her hands, she's got the syndactyly that sometimes people have. She did not have polydactyly. Go ahead to the next slide. And here her feet, she was rather had diffuse involvement pretty much everywhere. Go to the next slide, please. And here you can see the port wine stain. She, of the 3 was the only one that had the really classic port wine stain. And here you can see some of her facial changes. It's interesting that her issues were more from the chronic limb length changes and musculoskeletal issues, and she needed, again, symptomatic treatment, not surgical intervention. Go to the next slide, please. So again, we've talked about the increased hypercoagulable in some of these patients. There is a 22% increased risk of thromboembolic complications, and post-operative thromboembolic events are 10 times higher than in non-KTS patients for elective cases. If you're going to do elective surgery, they should be treated, if they're not on anticoagulated, with prophylactic anticoagulation for at least 2 weeks pre-op. Your vascular malformations can be a big source of platelet sequestration and fibrinogen consumption. You can get a bleeding issue as well as consumptive localized coagulopathy, and you can also get DIC from relatively minor trauma or even minor bedside procedures. So just something to think about. Next slide, please. So up to 30% of people will have the GU issues and require interventions on more than half of them. The obstetrical management of these women is variable, and the severity of disease, as I talked about, can progress with pregnancy, with new lesions developing, and you have to monitor the fetus as well as the mother. You need to work with your colleagues and plan a good anesthetic labor and delivery plan as well as an anticoagulation plan. Go to the next slide. The varicosities of the pelvis, the central nervous system, and the spine should be evaluated before any regional anesthetic is considered or before vaginal delivery. Again, cerebral varicosities can preclude vaginal delivery. Fetal growth must be monitored. The hormonal changes throughout the patient's life cycle alter the disease process, the thrombotic process, and the pain complaints. You need to have an increased awareness of the potential problems and a big team, because that's the only way you're going to be successful in taking care of these patients. And communicating is critical. Next slide. And I'm happy to take questions. The thrombophilia are variable. They're not necessarily specific to KTS, but there is an increased association in the KTS patients, and they have clearly an increased thrombotic risk. It's thought to be due to some of the endothelial cell activities. David, to answer your question. So that concludes what I was going to talk about, so we can have questions.
Perfect. Thank you. Thank you so much, Dr. Laura. I'll be honest, I just listened yesterday to a talk from a visiting lecturer on how to think about some of our arteriopathy patients, these young women who are diagnosed with a variety of connective tissue disorders that go on to become pregnant. And one of the really interesting conversation items around that was simply the shared decision-making. Sometimes physicians are getting consulted to advise on termination and whether or not deliveries can proceed with any element of safety, and kind of what that looks like when you think about C-sections versus vaginal delivery, and just the discussions, which vary, especially based on kind of the health literacy and age of our patients. So I get the sense that both you and Dr. Wright are navigating some complicated decision-making across the ages amongst your patients and their parents. And I wonder if maybe one or both of you would be willing to share a pearl or two on how you've been able to navigate that successfully, especially with such an esoteric problem, and in a way that's been, patient-focused and effective for you.
One of the I'll start. One of the safest ways for these people to have pregnancies to consider using their own eggs and doing surrogacy and in vitro. And so for people who want to have their own genetic children with some of these bad malformations, some of the new high-end maternal fetal options allow that to happen.
Thank you. Dr. Wright, I wonder if you've got some thoughts in response to that. You've been doing this for a long time with patients and families who are probably pretty scared. Oh, you're muted. I'm so sorry. We don't hear you.
Sorry, I thought I'd taken it off. Obviously, I'm not dealing with adult patients or patients during pregnancy or some of these other, issues specific to adults. I think for us, with kids, I mean, the challenge with children is generally, what you just mentioned, that parents often have a lot of fear because, there's kind of a lot of unknowns. Like, we can't always tell them, how this is going to develop over time or what kind of issues their child may or may not experience. We can kind of, tell them the things that can happen, the things to watch for, and, I think it just takes some getting used to it, and that this is a chronic condition. You know, sometimes they come and they're like, well, you mean you're not going to do anything? You know, they're kind of, and a lot of times they've been told by other physicians or other people, you know, that they've talked to about it, that, you know, that we can do this or we can do that. So they may come with some expectations. And I think, especially for younger kids, you know, if they're not having any symptoms, if they're not having any functional problems, then, you know, then we're probably not going to be doing any kind of real aggressive interventions. We're going to talk to them about what's going on, and we're going to, you know, make the recommendations of, you know, what to do for potentially prevention, like, you know, starting to wear a compression garment if that, you know, seems like that's feasible. And we're going to talk to them about what to watch for. You know, sometimes they're like, well, you mean you can't just make this go away? And, you know, that's not usually practical. So I think it can take some time for them to, you know, get used to that idea that this is something that's chronic and is not going to go completely away. It's going to have to be managed. It's going to have to be monitored over time.
And I think this is one of those patients, for a vascular surgeon, you normally don't get so connected. These people become so connected to you that you're their lifeline and their voice of reason, because they need you to bounce things off of you. And what do you mean nobody else has ever seen this? I mean, you know, the one mother was furious with me when I left Cincinnati because she felt like I was abandoning them. But again, you have to have an open door policy for these, especially the adolescents, because they go through all the things normal adolescents do, and they don't like to be considered abnormal. My teenager was happy she at least could explain to her friends what all these blue spots were that were coming up. And sometimes just giving them answers as things happen and reassurance is about all you can do.
Thanks for that. It looks like there's a question in the chat. What's your opinion on anticoagulation for 1 to 3 months? Are all cases of thrombophlebitis of the lateral marginal vein in KTS, considering the higher thrombosis risk in these patients? So how long do you anticoagulate these patients, these kids? What agent do you use? And then again, the site of the thrombophlebitis, always the lateral marginal vein or other veins.
Is that a question for me? I would say in general, we don't actually see a lot of thrombophlebitis in the younger, like in the children. Like, I think that's a complication that's more likely to be seen in the adult population. So I'm probably not the best person to, you know, to say what the guideline is for like adult patients who experience thrombophlebitis.
So some of it depends a little bit on, or a lot depends on what else is going on with them. The 3 cases I presented, none of them were the lateral vein. They all had both superficial and deep venous lakes that were involved. There have been fatal PEs reported with this from deep vein lakes. And when there's a extensive thrombus, I think like these 3 people have all basically been put on lifelong anticoagulation because they've had at least 1 or more episodes that are involving deep veins with potential issues. There was a child that was reported, I think it was like a 9 or 10-year-old that had a massive PE from an upper extremity lake that had a fatal PE. So they do happen occasionally. I think that just like with this young woman, when menarche hit, her estrogen and her hormones changed. And I think that's when you start to see children potentially have increased risk of thrombosis. I did not use DOACs on these ladies because they weren't around when I first started with them. And I think you have to be very careful to make sure that you don't have a anticardiolipin antibody and have a potential DOAC failure. All 3 of these ladies I had on warfarin and used Lovenox as bridges or heparin for short-term around delivery time.
Thanks, Dr. Lohr. Please keep your questions.
Just to bring up is that some of these people will get bleeding from their GI tract, and have to have interventions there as well. And so you need to make sure that you're aware of the association in the pelvis, not just with the bladder, but with the rectum and the colon as sites. So they need to be carefully followed there as well.
Thank you, Dr. Lohr. Dr. Wright, I want to ask you a question since I anticipate you get a fair number of these referrals, and it is in fact a rare disease. And one of the themes that comes up over and over again for patients with, whatever rare disease it might be, is that delays in diagnosis are common.
Mhm.
And there are challenges with access to care that often can delay treatment. And I
Mhm.
wonder what the landscape of that looks like for these patients in particular. Are there advocacy groups or other patient resources that you have found to be valuable? And do you think that if there are in fact issues with access and delays, if that challenges the natural history for these children?
Well, yes, absolutely. I mean, we see patients all the time who've gone without a diagnosis or have been given a diagnosis that doesn't, in fact, seem to be correct. And,
Mhm.
here where we are, I mean, we have a fairly large kind of region where, the nearest like vascular anomaly centers are, a few hours drive away. So I think, access to this specialty care is difficult, for many patients. So, a lot of times that happens for sure. And I think, I mean, there are definitely resources available. I mean, even through the ones I'm most familiar with would be ones through the Society for Pediatric Dermatology, but the International Society for the Study of Vascular Anomalies is there are groups that those organizations can connect families with as well. So once they get to us, we can definitely kind of give them that information, but many times like they're just kind of after on their own. Will say though, I think in the age of social media that has helped,
Yeah.
because you will find that people kind of find their group of like a Facebook group or something, of parents, families who have, a child with, a condition like this. So sometimes they kind of stumble on, a group of other people, and that can be, I think that can be a real support for some of them too. So.
Thank you.
But access continues to be an issue. And that's why, I mean, we see some adult patients, like a lot of vascular anomaly centers at pediatric hospitals. We end up seeing a fair number of adults just because they don't have anywhere else to go. And, they may have been seen somewhere at a pediatric hospital when they were young and they kind of aged out, or whatever was being done for them was kind of like maxed out. They felt like, well, I've tried everything, kind of don't really know where to go from here, but then they may start to have problems again and need to go somewhere. And we end up seeing some of those adults too.
Yeah, thank you for that. Well, I don't see any other questions in the chat. Let me just ask if there are any other questions for Dr. Wright or Dr. Lohr, or any other discussion points we should highlight this evening as it relates to KTS.
Donald, I'll ask a couple, make a sort of a comment and a question. I think Dr. Wright alluded to the fact that it's so important to have multidisciplinary care for these kids. We all know some parts of these syndromes, but it's really important to learn from each other. One of the things that we see a lot, I think, is misdiagnosis, as Dr. Wright alluded to. So there's overgrowth syndromes, there's CLOVES, there's Park-Weber, there's KTS, just to mention some of them. And I think you probably deal with a lot of that. You were told, your child's been told you've had this, you come to a center with expertise and have to pivot to have sort of cautious, what's the right word? Be skeptical, right? I wanted to ask both presenters, and Dr. Lohr, you alluded to the extraaxial, or I guess the truncal manifestations. Something like 10 or 20% of patients will have mediastinal or a retroperitoneal extension. And my question is there value, or is there some standard for serial imaging? I guess it would almost be like pan body MRI or something to anticipate problems. And are there guidelines or thoughts about what you can do to avoid complications? For example, GU complication, rectal bleeding you mentioned, mediastinal, or is it, do you react to problems as they emerge?
I think, again, it's so variable that you don't want to radiate people unnecessarily. And if it's not going to change what you're doing, or if you don't have an issue, we don't necessarily go looking for it. However, if they're going to have a procedure, you need to really evaluate that area to avoid problems, to place an incision that you might put in a different place. And just being aware that all of the venous lakes in the central area may not be known or symptomatic. And so for interventional planning, you want to scan people around the time of the intervention.
And then the last sort of maybe a philosophical question, or maybe not philosophical. We've talked a lot about how these are difficult diseases to treat. You're reacting to the disease. Is there any promise of, who knows, cell-free DNA diagnosis in moms and then some sort of targeted in utero therapy?
I can't speak to specifics. I mean, I think that, that's something that may be coming. I'm not like aware of any like actual actual data, about whether that's been done. I feel like I saw mention of like some prenatal diagnosis of these conditions. Sometimes you can see, some evidence if you have a large lesion in the leg or intra-abdominal or something like that. Sometimes you might be able to see that on a prenatal ultrasound, or, have a suspicion that there's something there. But as far as like the actual genetic testing, I haven't seen anything about that yet.
And most of these are spontaneous mutations, and the parents usually have nothing to pass to their children. I mean, they have normal, most all of them have normal children with no anomaly.
Right.
It's a matter of making it safe for that to occur. And there are some pretty interesting things being done with the prenatal ultrasound. The problem is that if you see it, the options are not good for pre-delivery treatment. There's nothing you can really do to resolve it at that point in time, with
Right.
the exception of a termination, which is, to me, is not a treatment. Sorry.
Right. Yeah.
Okay, any final questions? Right, the second part of our time together was going to be just a brief overview on chronic venous disease or venous insufficiency in children and adolescents. So related, but a little bit different. And I anticipate that there'll be some input that Dr. Wright and Dr. Lohr can share. So I've got a handful of slides that we're gonna breeze through that may or may not prompt some additional discussion. And we may in fact end a little bit early tonight based on how this moves along. Full disclosure, while I have no financial disclosures, I will disclose that I'm just not an expert. I don't know that anybody is for most things in this pediatric space, but by, at least as a vascular surgeon, seeing patients with a variety of vascular problems, sometimes referring doctors simply don't know who to send their patients to. They don't know what a diagnosis is. They want somebody who's willing to at least think about it. And some of my practice patterns and habits and awareness have evolved simply just based on exposure and some necessity. So I am a vascular surgeon. I now work at Duke, but spent 2 decades at the University of Michigan. I was mentored and trained by vascular surgeons, most notably Tom Wakefield, who Joanne Lohr referenced earlier, and a man named Jim Stanley. The bulk of my clinical work, and I would say my own content expertise, happens to be in the arterial space, mainly as it relates to renovascular hypertension. But again, by default, I've had a handful of children come with a variety of problems, and infrequently it's venous disease, and more frequently it's something else, but we're able to often get the kids to where they need to be. And I know that we've got kind of a diverse audience, and so I don't want to belabor too much really basic stuff, but I did just want to qualify the concept of chronic venous disease, often referred to as chronic venous insufficiency, but essentially this is truly a spectrum of disease that is thought to be secondary to venous hypertension. And really at its foundation implies that the calf muscle pump and the venous piping or the valves are just ineffective in circulating venous blood. And we classify venous disease based on 4 domains as it relates to the clinical classification, which often is associated with severity, with C1 suggesting there's a venous pathology, but maybe no visible clinical exam finding. C1 and 2 would be pretty modest early disease patterns, often spider telangiectasias, varicosities. C3, C4 is more moderate severity disease where there is edema and or really more chronic inflammatory changes. And C5, 6 implies some degree of either active or healed ulceration. The E stands for etiology, whether that's congenital or developmental, primary or secondary. A good example of secondary being somebody who's developed venous hypertension from post-thrombotic syndrome following a DVT. The A reflects anatomy and whether that involves reflux, for example, or occlusion of a superficial vein, a deep vein, perforating vein. And then the pathophysiology, again, behind venous disease is generally related to either valvular reflux, some obstructive component, or you can see both. And I think it's also just important to remember how venous disease is diagnosed. And we haven't talked about the details of ultrasound, but I think with our kids, it matters because not everybody has access to a vascular lab that is either comfortable or capable of really assessing this. And so venous duplex reports come in a variety of ways, I think, but in an ideal setting, there's a comprehensive venous duplex ultrasound that is performed, and it's in accordance with some type of societal guidelines. We have an intra-societal accreditation society that oversees our lab here at Duke and our lab at Michigan. And when these studies are performed, there's a really careful evaluation of the deep and the superficial veins. And it's important that the patient is really upright, either sitting upright or standing, not supine. Additionally, that leg that's being examined should not be bearing weight. And all of the deep veins, inclusive of the common femoral, the femoral, and the popliteal vein, should be imaged. The superficial veins are evaluated at 3 to 5 centimeter intervals or stations, and accessory veins like the small saphenous, anterior accessory, these veins and perforating veins also should be assessed. Compressibility confirms patency as opposed to acute or chronic thrombosis. Venous flow and then augmentation patterns are assessed, and reflux specifically is elicited by a modified Valsalva maneuver. And sometimes that can be challenged by patient age and cooperation. Manual compression is also used as an augment in these cases. And reflux time simply quantifies the duration of abnormal flow reversal. And pathologic reflux time differs depending on whether we're considering the deep or the superficial vein, with a reflux time over 500 milliseconds used to define valvular incompetence in the superficial system or perforators, and we use greater than a second in the deep system. I have one case because I have one case of really severe venous disease that I think is relevant, and this is not an occlusive post-thrombotic patient, but this is a really interesting child, a 13-year-old who, despite genetic testing, had no variant identified, but she in fact has many developmental anomalies that all come into play here. She has a single kidney that she was born with, a history of tethered cord, 2-drug hypertension requiring ACE inhibition, and this chronic leg ulcer. She was referred to me during my time at Michigan for mainly what was felt to be an arterial problem. So they sent her to us with cool feet and really no palpable femoral pulses and concerns that this was a wound of arterial insufficiency. But this location and some of these wound features were far more worrisome for a venous ulcer. And in fact, we did perform a duplex study that revealed patency and no venous reflux. But interestingly, she had a duplicated femoral vein. And she had scattered telangiectasias throughout, and this wound was very painful to her. She had some interesting CT imaging that suggested aortic occlusion. And you can see maybe some really tortuous collaterals that were reconstituting an iliac artery on the right, and then ultimately a femoral, which you can't see here on the left. But she had far more profound occlusive disease on the left, and in fact, an ABI that was around 0.6. And we had concerns about her ability to even tolerate routine compression, given her severe PAD and the symptoms associated with pain around that ulcer. And so really to ensure she could have treatment for the venous wound and for some other symptomatology, we offered her reconstruction by treating her arterial inflow, which was done by way of a right aortoiliac left femoral bypass. And we also performed a punch biopsy of her wound, which in fact revealed ulceration with angioproliferative changes and pandermal reparative fibrosis and hemosiderosis, and all of that favoring a venous stasis ulcer. Once she had her arterial inflow restored, and she was able to be active again, to mobilize her leg, exercise, and specifically walk regularly, exercising her calf muscle pump, and tolerate compression, her ulcer actually healed within about 6 to 9 months, and she's done very well since that time. What I thought was super interesting in the operating room is right around the area where her aorta kind of terminated, and she didn't even have any aortic cord to speak of. Her cava was entrapped by her overlying aorta. It almost looked like there had been flawed development, such that there had been her duplicated caval system, and it wasn't in line down the whole length. Essentially, where the aorta is occluded, the cava almost took a turn and then was a different inline vessel. And so there was some entrapment with some neurosplanchnic tissue and her aortic anatomy. And I honestly believe that she had some degree of potentially kind of occlusive outflow obstruction of her cava. And I've looked and looked and looked and can't just find any really good preoperative imaging that had delayed contrast imaging to support that. And again, she didn't have reflux, but I thought that was just a really super interesting case. Venous disease in kids is super uncommon, and we see an incidence in school-age children that's estimated at 0.2 to 3%, with physiologic reflux described far more often, especially as children age into the teenage years. And we have classically extrapolated reflux study parameters from adult protocols. We also know that the most common form of chronic venous disease in kids is either from post-thrombotic syndrome or KTS, which was just so nicely reviewed for us. The differential diagnosis when kids are coming to your clinic, if they do with discoloration and edema, which is often the case, is really broad. And when I suggested that, I see a handful of kids with these lower extremity challenges, I'm 100% confident and have shown that the majority of them don't actually have venous disease clinically, but some alternate diagnosis. And so often what I'm diagnosing is some type of vascular instability or vasculopathy, where there's small fiber neuropathy and challenges with vasomotor tone, increased local metabolism like you would see with erythromelalgia or acrocyanosis. Those being respectively panel A and panel B, or even Raynaud's. Sometimes I'm diagnosing something like complex regional pain syndrome, which is definitely a neuropathic diagnosis, but frequently associated with discomfort, really interesting pain sensations, temperature and skin color changes, and other things that might trigger somebody to think there's a vascular problem. Lymphedema, vascular malformations and tumors, generalized essential telangiectasia, and even sometimes cellulitis. This is a picture of primary lymphedema, and that's different than the swelling that we would see in classic chronic venous disease because it involves kind of this hump, this dorsum of the foot, and that's a really differentiating feature. So when I was early in my practice, I looked back through our clinic referrals and found about 20 that had been referred for chronic venous disease on paper, meaning they had some type of varicose vein or swelling, which prompted the referral. And most of them were in kind of a preteen, early teen period, but we had a handful of kids that were less than 10, and the majority of them presented with either swelling or varicosities, with discoloration being less common, and about just under half had bilateral disease. And we found that the mean GSV diameter observed at the first station was about 0.5 centimeter, and there was no significant difference in maximum diameter between the groups. And we also found that patterns of venous reflux really varied across the diagnoses. Half the patients demonstrated some level of accessory reflux, which we defined in this series as reflux affecting the perforator vein or the small anterior or posterior accessory saphenous veins. And in addition, we found isolated deep venous reflux only affected those cases in which an alternate diagnosis was made. And so importantly, we found that venous reflux at some level was noted for everybody, but almost half of them had some other diagnosis that we were able to confirm, which made me wonder if the venous reflux was secondary or even physiologically relevant at all. These two figures really highlight the maximum superficial valve closure time. So when we looked at the GSV, I told you a significant abnormal finding is when that closure time is over 500 milliseconds. And we saw an average in patients who had either chronic venous disease confirmed in KTS that was, up to over 4,000, and that was significantly higher than the maximum superficial valve closure time in those children who had an alternate diagnosis confirmed. And interestingly, bilateral symptoms were present only in the minority of patients who either had chronic venous disease or KTS confirmed. But regardless of the diagnosis, the majority of patients demonstrated this reflux. And we sought to then understand that a little better. And so we then found 18 healthy controls, and these were the children of all of the people that worked at our cardiovascular center. And we separated them into these specific age groups, 5 to 8, 9 to 12, 13 to 17. And we found really two important lessons. And the first was that the great saphenous vein continues to grow in diameter through the teenage years. And so you see that reflected in the saphenous vein diameter shown here. And we also found that 60% of these perfectly normal asymptomatic kids who were coming in to get a gift card had evidence of reflux at multiple stations, really raising the question about whether or not this is preclinical finding that is going to progress, or if our adult protocols are not applicable to kids. And there is a little bit of data around the natural history that I think is relevant. And some folks who do believe this is going to precede adult onset chronic venous disease. And the Bacchum study, which is probably the most relevant study that was published just before 2010, followed 10 to 12 kids who were diagnosed with preclinical reflux to an age of 31. And they found the incidence of venous disease increased with age. Varicosities tended to develop by puberty. The length of GSV reflux also increased with age, and truncal varicosities were almost always preceded by reflux in that same vein. And so they concluded with their data that preclinical reflux represents about a 30% risk for the development of truncal venous varicosities. And then there's been a more recent abstract, at least published in the JBS Veno and Lymphatic edition in 2023, where authors followed about 65 kids using high resolution ultrasound out at least 4 years. And they found that about 40% of these kids had some type of venous abnormality, all remained asymptomatic over those 4 years, but they did find functional progression that kind of mirrors what was shown in the Bacchum study. And finally, I would say most recently, earlier this year, is the first data I've shown that's proposed therapy by way of ablation for children. They liberalized, although I guess it's not totally inappropriate, defining pediatric age out to 21 years. And these authors treated 13 children with an average age of 18 years with RFA, EVLA, sclerotherapy, or phlebectomy. They found no major complications. They reported 100% technical success, although their follow-up was limited to 5 months. Importantly, there were no cases of venous thromboembolism. And so how have I managed these patients when they come to my clinic? I certainly counsel them. A lot of this, I think, is education and risk factor modification, targeting obesity, tobacco use, prolonged sitting, standing, sometimes straining for your heavy weightlifting young men, wrestlers in particular, that might make it worse. I have chosen to survey them annually to every other year with venous reflux studies just to monitor progression. It is a risk for superficial venous thrombosis, as we've discussed. And in general, I offer routine measures of vein health, inclusive of compression and walking and regular elevation. But to be fair, as referenced, teens struggle with this a little bit. Nobody likes compression socks, and generally using something that's lower than a traditional prescription grade, something that you can get over the counter, and something usually off Amazon that's cheap and colorful and fun and doesn't feel like ugly old man socks seems to work a little bit better for those kids. So I loved those compression garments that Dr. Joanne Lohr showed that looked kind of like tattoos. So those are my thoughts when I've had patients come to my clinic with these challenges, and I'd welcome again questions and frankly, any guidance or thoughts from Dr. Lohr or Dr. Wright in particular, who I know see a spectrum of pathology in their clinic. And again, thanks so much, everybody, for being with us tonight.
My comment, Dawn, would be to always look proximal for obstruction.
That's right.
Because so many of these kids, just like the one you showed, have a hypoplastic or underdeveloped anomaly or a duplication that you may not appreciate just on your Doppler. And so the common femoral Dopplers and your duplex can be misleading on some of these young kids. And so you want to always look proximally for something that's maybe not there, causing an obstruction and symptoms.
That's a super important point. Thanks for raising that. And I will say, for the folks in which an alternative diagnosis was not confirmed and there was chronic venous disease or deep venous reflux really qualified, they all underwent an MR venogram. So we're pretty liberal with that. And to be very honest, for at least this very, very small pilot series, did not find any evidence of compressive anatomy. Although you would be familiar with this, Dave Williams has a huge kind of adolescent practice of just what you've described, caval agenesis, and whether that's primary or whether that's secondary to some remote thrombotic challenge, it's unclear, but they certainly go on to get post-thrombotic syndrome and pretty advanced C3, C4 disease. And kind of recurrent thromboses down the road. That's such an important point. Thank you.
Well, the other thing they get is if they're not reconstructed and it's significant aplasia or agenesis, they get portal venous and mesenteric decompression, and they get hemorrhoidal bleeding, and they get visceral bleeding. And now there's techniques. It was interesting. I was just watching a meeting at endovascular therapies where they were talking about recanalizing the portal venous system, even when it's partially thrombosed or cavernous changes, and to the point of stenting and using tips to maintain outflow to get rid of some of the gastric GI bleeding complications that are occurring in these young patients, 20s or 30s, that have had recurrent episodes of clot and just have decompressed through their GI tract, which can result in lethal bleeding.
Wow, thank you.
One thing occurred to me, I'm clearly not an expert in venous disease at all, but in the vascular clinic, we do get a fair number of referrals of babies, infants, and young kids who have episodes of kind of bluish or violaceous,
Mhm.
discolored feet. And the parents are, always worried that they have bad circulation to their feet. And one thing that can be really helpful is just to put a pulse ox, on their toe and just show them the feet may look blue, but it's not because there's lack of blood flow, to their feet. Obviously, also you can feel the pulses and reassure them that there are pulses, but showing them that the blood is oxygenated can be helpful. And then also, reassuring them that that's not the same as central cyanosis, like inside the mouth or something that might indicate some sort of congenital heart, problem. So that's just one thing I found to be kind of a little more convincing to parents. And I just chalk that up to, I just explain it as like vasomotor instability, an immature autonomic nervous system, and something that is going to get better with time.
The other
That's a
group-
really-
the other group, John, to ask about when you're taking your histories, ask about umbilical vein catheters and people that were in the ICU, whether they were treated as a 4-year-old for Hodgkin's that had lines in and that kind of stuff. Because I've had several younger patients in their teens that as 10-year-olds had been treated with aggressive lines and things, diseases.
That's right. Thank you. It looks like Jason Johanning has his hand up. Jason.
Yeah, Dr. Coleman, thanks for putting this on, and fantastic. I had to drop for a few minutes, so I apologize if you address this, but I would echo your comments about the fancy compression stockings on Amazon and Google Shopping. I've gotten a lot of compliance there, but the challenge comes up and you presented the data on, well, we can treat anybody pretty well with vascular superficial venous disease, but do you really want to go treating a 21-year-old female who has some reflux in her GSV, is going to potentially get pregnant and drive all that compression and pressure down the deep system? Because I think, yeah, it's easy to treat now. And I've always advocated doing stab phlebectomies, isolated sclero for the younger female patients, as we've talked about it today. And then once you're done with childbearing, then we shut your GSV down, because that's really your release valve as far as I look at it. Any thoughts on that? And how are you treating that 21-year-old female with unsightly varicosities?
Well, thanks for the question. And I'll confess that at this stage in my career, I see a lot less venous disease than I once did. But I was always super reluctant to treat axial reflux, especially in C1, C2 disease and in young patients, for all of the reasons that you just shared. I think, and maybe I probably shouldn't have shared that slide, but it was, one of the more recent data points that just suggested that people are in fact doing it. And I wasn't even aware of that. But, in general, I've been super conservative from an interventional perspective. And anybody who's prepubescent, and then again, I think for the patient phenotype that you're describing, I think that's somebody also to temper. Sometimes their varicosities really hurt them, in which case a sclerosant procedure can be super effective because you've treated that space of localized pain, and that buys them some time. So I sense that how you're managing your patients is similar to how I've previously managed mine. And I wonder, Dr. Laura, if you've got additional insight with your own practice or best evidence from the venous community through your work with the AVF that you could share in this capacity.
Yeah, if you look at Dr. Ellen Massoud's appropriate use criteria in the new American Venous Handbook of Clinical Guidelines, the appropriate use criteria would say C1 and C2 have almost no appropriate indication for treatment, and especially in a young woman. So I would refer you to those directions. And again, I think it's very much symptomatically directed. And a lot of times, the hormonal manipulation can be done with the help of our OBGYN colleagues to get rid of some of the symptoms of perimenstrual issues.
Thank you. Other questions? I do want to respond to Dr. David Gitlitz, who's asked about having copies of the slides. Mary, correct me if I'm mistaken, but I believe all of these webinars get recorded and they're archived to our website. So they're visible and available to anybody who comes a knocking to the website, APSA members, SVS members, really anybody.
Yes,
So they should be easy to
I'll
easy to get.
I'll send the recording around, the link to the recording once it's uploaded.
Super, thank you.
Thank you.
Any other final questions, pearls, discussion points? All right, well then thank you to both of our speakers tonight, Dr. Wright, Dr. Lohr, to my partner, Dr. Rothstein, to the support we get from Mary and Reva, and to all of you for joining us. We all get 9 minutes back. Be safe, stay warm if it's cold where you're at, and we'll look forward to next time.
All right.
Thank you.
Thank you.